Thank you for joining today's PCPCC webinar, Primary Care Measurement, What's Working and What's Not. During the webinar, you will hear 4 experts discuss various aspects of the person-centered primary care measure and how it can be utilized to represent high-value primary care for patients, clinicians, and payers. Hello, everyone. I'm Julie Shills. I'm facilitator for today's webinar. I'm Senior Director at Mathematica and also the Executive Member Board Liaison for PCPCC. We're so excited to have you with us today. For those of you who are not members, I'd like to take this opportunity to encourage you to consider doing so. Feel free to reach out to Jennifer Renton, Membership Coordinator, at the email located on this broadcast. If you're interested in joining the team-based primary care movement at PCPCC. PCPCC brings together more than 60 organizations committed to empowered team-based primary care as a foundation for a high-value delivery system. As an executive member, and I am one, you can be an active participant at the table that's already set with various stakeholders, including CMS, join a collective voice of respected thought leaders, and help us directly and effectively respond to healthcare environment, forging a path forward to elevate primary care so it can deliver the promise to patients and families. And finally, please be sure to save the date for PCPCC's annual conference. It will be this fall in Washington, D.C. on November 4th and 5th. And you can see on the slide, we have some amazing speakers and an excellent agenda. The registration is open now at pcpccevents.com. And because you're participating with us today, the added value you get as a participant of today's webinar is you can receive a $100 discount off the registration by using the code webinar 2019. Be on the lookout for our next webinar, Goal-Oriented Patient Care, Caring for Patients with Alzheimer's and Dementia. This will be October 25th at 1 p.m. Eastern Time. The PCPCC website has all the details, and hopefully you're signed up for our emails. So if you have a moment, please, I think everyone's on mute. The presentation and the recording will be available at the end of our time together. And we will also have time today for questions and answers at the end of all of our presentations. So with that, I'm so pleased to welcome today's panelists, very excited about this topic and the conversation we can have together. Rebecca Etz is a cultural anthropologist at Virginia Commonwealth University with expertise in qualitative research methods and design, primary care measures, practice transformation, and engaging stakeholders. Rebecca is also currently a co-chair for the Larry Green Center. We also have Amir Kassan, who is a trained physician, health economist, methodologist, clinical epidemiologist, business administrator, and leader. He's responsible for leading the American College of Physicians, or ACP's, evidence-based medicine and clinical practice guideline programs. Also, Jay Lee, who is the director of primary care at CareMore Health, where he leads the development and implementation of next-generation primary care models across all markets and continues to serve medically and socially complex patients in Long Beach, California. And last, because patient voice and having an advisor is so important, we have Janice Tufte from Seattle, Washington. She's bringing our patient voice to today's presentation. Janice participates in many activities across the country and many improvement research projects, PCORI, NQF, has published papers, so we're very excited to have her as well. So with that, I am going to turn over the presentation to Rebecca Etz.
Great. Thank you for joining everyone today. I really appreciate it. We're doing a webinar I get that. But I want you to take a moment and not think of yourself as just listening to a screen, but think about how you are assessed and judged every day in terms of your work by the people around you. And that is the basis of what we're looking at how people value us and how they value or reflect that value back to us. So when I got started on working on measures, our team was approached by the Robert Wood Johnson Foundation essentially to do a bright spot study. They wanted to know if I could do an interview study to identify a cohort of exemplars in primary care practice, places where they were doing high quality, clinically excellent care, and they were doing something that was sustainable even outside of any necessary reforms. These could be examples that other people could be inspired by and follow. And we did the usual lit review, but really what was happening on the ground in practice was in advance of what we saw in the literature. We ended up doing this interview study, and within 5 months, I spoke to 1,200 thought leaders in primary care and interviewed 250 practices around the country. And here's the thing that really stood out. So how do you decide who's high quality and what is clinically excellent? In primary care, that's actually a hard thing to do. And we had measure questions that we asked, and people wanted to know if they were PCMH level 1, 2, or 3. But all the practices that I spoke to that were identified by colleagues and in the literature as exemplars said, yeah. So we do that stuff. We report on that stuff. So glad somebody's looking at it. But truly, it doesn't help us to understand if we are providing any benefit to our patients, nor does it help us understand how to learn how to do what we do better. So we do this other thing, and that's what you really want to know about. And I became fascinated by that, and I wanted to focus on that because what I could hear in their undertone was that there was this tension across the landscape of what measures are and what they do to people in everyday primary care practice. These were folks who were supposed to be at the top of their game, and they were telling me that's not how we got here. So my approach was then to say, so we need to reframe the problem. We need to understand what it really is. We hear all the time that there are too many measures. That naturally leads us to a problem-solving technique of reducing the number of measures we have. It's not clear what we mean when we talk about measures, and it's also not clear that simply reducing the ones that we have is helpful. What became crystal clear to me during these conversations was that we didn't have any measures of our own, ones that allowed us to reflect back what we needed. So then I thought about, well, what are measures? And measures really are about self-determination. A field that doesn't have any measures of its own is a field that doesn't have the ability to self-author. We were missing that, and that was part of the outrage bubbling beneath the surface. So I was interested in talking to people about how they see potential and aspiration in the world of primary care, how they interpret that, how they would like it to be shared and reflected back, with the understanding that measures are a very purposeful way of communication. They indicate to the people in front of us that this is what's most important, and here's how I'm doing with that most important element. You can understand my value and professionalism because of it. Made it clear that we needed to start over. And the way we started over was to begin with evidence that matters, not to build on precedent. If the problem was baked into the precedent, then building on that would give us a false foundation. So we started over. We reached out to hundreds and hundreds of stakeholders to find out what was most important to those seeking care and those delivering it. We then took that information, we put it in front of a set of experts, really people really informed about policy and measurement and primary care, and said, how do we make sure that we refine this and negotiate this in a public setting in a way that we can operationalize it and it can feed the needs of everyone? And then we took it on the road and we did some rapid cycle testing and implementation of what we found. So the first step was finding the evidence that mattered, and we used crowdsourcing for that. We did an open-ended online survey, hundreds and hundreds of people, patients, clinicians, employers, and payers. And we said, how do you know good care when you see it? What's most important to you? What do you want to know when you want to assess it? When we got their answers, we took everything that they said and we plotted it in a scatter graph. And when you're a qualitative person, an anthropologist like me, this is what we do to scatter graphs. I don't like black and white little dots on the screen. So I made it colorful. And I put all those little dots are the answers. There are about 10,000 answers plotted there. And along the bottom axis is the line of all the people and their answers. And on the y-axis or the side is how we organized our coding of those answers. And I purposefully grouped in the middle those codes that relate to the measures we currently have. And the higher intensity things got coded there, the whiter it got, like a heat map. And the less coding, the bluer it got. And what you can see is that only 38% of what people identified as important is actually being measured. And man, it's really being measured. That means that 60% of what patients, clinicians, and employers identified as most important to them, the way they know how to see good care and the way they know how to assess it, is completely in the dark. It's a literal tunnel vision. Through that analysis, we identified 19 quality indicator areas, discrete areas, based on people's responses. We took that on the road and we had a conference. We held it in DC for 2.5 days. We invited international and national primary care leaders. There were actuaries, there were patients, there were family medicine, pediatrics, internal medicine, occupational therapy, behavioral health, funders, insurance companies. We really had a wide scope of people. And we asked them to help us for 2.5 days, kick the tires, refine what this is, talk about having all of primary care represented in a single voice, and what is most important. We ended up reducing it from 18 quality areas to 11. All those conversations were recorded. We took those conversations and we analyzed them, and we found two things coming out of the conference. The first is that primary care actually does what we've always said that it does. It takes two competing ways of knowing, a scientific way of knowing and a social way of knowing, and it holds them together in one coherent whole. We take both of those things as equal and important, and we make sense of the person in front of us through both their biology and their biography. The second thing is that the elements identified are broad in range and interdependent, and any assessment of them requires that we address all of those things together and not separately. It's not additive. So once we did that and we had our 11 items, we used our analysis to turn those 11 areas into patient-reported items, simple questions using the language that people used when they responded or that they used during discussion. So you'll notice when you see this measure in a moment that it has no intermediate clinical outcomes. It has no process outcomes. It doesn't have anything that looks like proof of delivery of service. It is what people found most important when they are delivering or seeking care. We fielded it 3 times. We fielded it in an online population for which we captured lots of demographics. We fielded it in person in community health centers, private practices, pediatric practices. This was all about refining the language, knowing that it was reliable, knowing that it was valid, and that it could show variation across settings. I'm going to quickly walk through how we validated it. For those of you who have questions about it, I'm happy to answer them offline if we don't have time during this session. But I know not everybody is familiar with these analyses. So the first thing we did was factor analysis, and I made this little diagram to explain it. In factor analysis, you get a score between 0 and 1, and the goal is to get at least a 0.4. If the question that you're analyzing gets a 0.4, then we know that question is good and appropriate for assessing the thing you're trying to assess. What you see in our 11 items is that all of our questions are well beyond the green and into the blue. It is unusually strong in each item. It is, the lowest is even in the 0.6 range. The second column, the item total correlation, tells you that there is no redundancy among these questions and that they are all actually interdependent. The math proved out what people said in the room and through the surveys. These things have to be held together. They are broad in scope and coherent in discipline. Next, we look at the score. Our score goes from definitely, mostly, to somewhat, not at all. It's basically a scale of 1 to 4. And unlike many patient experience surveys, you can see from this diagram here that our scores form sort of an arc. The full scope of our scale was used. People did not just circle the end because they liked their doctors. They actually answered each question individually. And the last kind of statistical analysis is rash modeling. What's really important to understand about this particular diagram is simply that what you see is, once again, there is no redundancy. Everything is spaced out along the scale that's important to rash modeling. And it is spaced out showing that things go from really easy to answer at the -5 to really hard to answer at the +5. And a range in easy to hard questions is part of what helps us to know whether this is assessing something and can be fine-tuned to see variation in a setting. So the next thing we did was look at how does this relate to other validated instruments and how does this relate to differences in the population. I can talk about these at another time, but what's important to know here is that our measure is very closely aligned with a measure that assesses a patient's self-reported ability to self-manage and understand their health and illness. It is also strongly aligned with a measure that speaks both retrospectively and proactively about cost and utilization of services. When we ask people, if your doctor received the answers to these questions, would it actually help with your care? They overwhelmingly responded yes. And of the 2,200 some odd people who answered the survey, there were a big fat 17 who had any trouble answering any of the questions. It was almost negligible. We looked at how people answered in response to the usual social demographics, age, income, gender, minority status. None of these caused any significant variation in the findings, showing that this was not about identity politics or the particular illness you have or the kind of insurance you come with. This was strictly about, were you receiving primary care and did you rate what you were receiving to be good? I want to be clear that I'm not saying that all the measures that came before weren't good. I put this slide in here a little bit tongue-in-cheek. Every old idea was in fact once a good idea and is necessary to get us to the next idea. I think all the measures that we currently have are necessary and that we actually need more. We need as many measures as we can possibly get to help us understand clinical care and decision-making. That is something quite different from quality measures. We need lots of measures to help with clinical decision-making, to help us understand good professional judgment. We do not need all of those measures to determine quality or performance. And that is what our new measure shows. So briefly, next steps, we have since validated this measure in 28 languages in 35 countries. We're doing the early analysis on that. The fact that it's validated across so many different settings shows that what we are getting at is really not identity-based. It's not based in a particular payment system or reward system. It is totally about primary care and whether it's there and whether it's good. We have some partners that we're working with in the US to do some trials to get direct associations with traditional comparators like the MIPS measures, as well as cost and utilization. We're developing tools to show how it can be used to support quality improvement. Those things are ongoing. We have international trials ongoing in Japan, in China, and in Canada, and a new one starting up in the Netherlands. And we are in the process of getting endorsement for this measure. So we've already submitted it as a self-endorsed QCDR measure. through CMS, and we'll be going for full endorsement next year. And we are putting together our application for NQF endorsement in January. Through conversations with them, it seems like that's going to be an easy thing for the measure at this point. So that's what I have to share. I really appreciate it. I know we're going to move on to our next presenter. Anybody who's got questions for me, I'm happy to answer them at the end or offline if we run out of time.
Good afternoon, everyone. Thanks so much, Rebecca. This is Amir Kasim, and it's humbling to be presenting with the esteemed speakers in today's panel. Thank you so much for PCP for inviting me, but and actually most importantly, for 300 or so attendees in today's panel. So very impressive. And my job is to talk about, is it time to re-envision performance measurement and performance measures? And you're going to notice that I'm using both terminologies because I do think that we keep on interchanging them, and I think those two are completely separate concepts. A little bit about ACP. We're the largest medical specialty society in the United States. We now actually have 159,000 members. I should update this slide. And our headquarters are in Philly, with our advocacy office located in Washington, D.C. And I wanted to start out by just putting up how much money are we spending in our healthcare system. It's $3.4 trillion at this point, and I like putting the zeros because I'll be honest with you, I have it's a difficult number, the trillion. It's hard to absorb for me how much money are we spending, and by 2025 we're going to be spending $5.5 trillion. This is a lot of money we're spending. And the bottom line, it comes down to that everyone wants a little bit piece of pie because of so much money we are investing in our healthcare system. And if you look at this slide, I just want to go over some fun facts. And I think you have seen and heard how much money we spend in our healthcare system. And all you're going to see in this slide is look in the extreme left where the United States is listed. And you can see that we're spending the most here, right, compared to the rest of the country. And you can generally see there's some other countries that come close to us, but we are spending over $10,000. And at this point, that was 2017 numbers, by the way. It is the healthcare spending per capita. It is essentially the biggest item in anyone's household consumption at this point. So we need to be very cognizant of how much money and how many dollars are we all putting into this in the healthcare. And this slide takes the story a little further back. On the left side, you can see it's 1980. And all I wanted to show you and take home message from this slide is that we were actually pretty close to the rest of the world at one point in time. In 1980, if you look at how much money we were spending, where it was at that point in time, forget about even at the numbers, right? Versus where we are all at. And of course, the spending keeps on going up. But you can see the slope over here, the steepness, the steep slope that you're seeing. The slowly, U.S. started diverging from the rest of the world. And in return, on this slide, again, the point I'm trying to convey over here is that even in the Western world, or those who are more developed countries, they're spending pretty much similar amount, and their life expectancy is pretty close to where it should be. Versus U.S. on the right side, we stand alone. We are spending more because that's the amount you're seeing on the x-axis versus our life expectancy. Because life expectancy is just one of the ultimate outcomes that you want to increase, right? And you can see the amount of money we're spending versus our life expectancy is lower than most of the even the European countries. And hold on, it shouldn't have gone back because it is going backwards, and I am not sure why is that happening. Okay. I'm pressing the next button. There you go. It started moving in the right direction. Oh, no, it's not moving in the right direction. This is where I might need help, guys. Thank you. You can go to the next slide, please. Perfect. And this is just again showing the amount of where the overall rankings, the various processes that are used, the care process, the access, the administrative efficiency, equity, healthcare outcomes. If you just look at across board, US is generally ranked quite low, pretty much 11 out of the 11 countries that are displayed over here, except for we do pretty well when it comes down to the care processes. The bottom line is we're spending a lot of money, but we may not be getting what we would like to get out of it, and that's what been raising the red flags. The slide is again moving in the other direction. I might need technical help.
Okay. I mean, you can do an easier forward key on your
Yeah, I'll just tell you to move it to the next slide. Can you move to the next slide? Okay. So why are we doing this quality and cost discussion? Value-based discussion, value-based purchasing, outcomes achieved relative to the cost. Everyone is talking about it. Patients are very interested in talking about quality of care and what quality of care is being provided by their physician. But that's the general trend if you think about it. Whether we are traveling, we look at hotels, restaurants, where we're gonna be eating, or we're gonna buy TV, refrigerators. We're all looking for the rating. So that's essentially the norm now, and that's what patients look for. Peers want to basically they want to cut costs and improve the quality of care. Performance measurement is an important tool, right? It does help physicians, health plans, stakeholders to identify gaps and understand where quality of care needs to be improved. But the performance measurement continues to be generally focused on what is easy to measure, something along the lines of what I think Rebecca was saying. Next slide, please. And are there too many performance measures or too few performance measures? We can have that can be a topic for a completely separate presentation. But this is just not a new concept. This started in the mid 90s where folks at that point started talking about the healthcare financing, the quality of care, how much money and how much dollars are we spending in care delivery. But what has happened at this point is this slide just tells you how many performance measures that are out there. Now, whether they're too many or too little, we can argue about it. But NQF alone, you can see, has got 622 performance measures that they have endorsed. Or CMS Quality Payment Program has got now over 270 performance measures. So, and the reason this has ended up happening is that some of us believe that even imperfect measurement accelerates improvement. Using measures improve measurement, and then frankly there are no other options at this point how we can measure quality of care. Next, please. And quality measurement works. Without getting into detail about this slide, the two things I put up there: mortality rates and hospitalization rates. And since measurement has been put into place, you can see over the last 20 years or so now, there has been a continuous decline, which is good news, from 1 year mortality to 30-day mortality, and even hospitalization rates. It's been one issue that keeps on coming up again and again. So quality measurement that has shown that it does work because these changes did happen once the quality measurement has been put into place. Next, please. But there is also emerging evidence that perhaps measurement may be causing harms. I don't know if many of you have seen this slide or not. This talks about hyperglycemia rates and hypoglycemia admissions in the hospitals and in diabetic population. And if you notice over here that over the same time period that I just showed where hospitalization mortality went down, hyperglycemic episodes actually did decrease, right? Because people have been focusing on tight glucose control. But what has ended up happening over here that you can see there has been an increase in hypoglycemic episodes. Next slide. And patient-reported outcomes, of course, we're all talking about it, but there has been issues with that. The methodology behind it is quite complex. Next. And at this point, what is happening is that MedPAC just look at the MIPS measurement, and what the bottom line MedPAC report said that MIPS is not fulfilling its goals, and therefore it should be eliminated. And the commission also said it did not reach this conclusion hastily. Next. There are many papers that have been published, examples that about we need to cut down on the performance measurement. This is another example. Can you click next over here, please? That talks about the doing the same old is not working out. Next. Don Berwick asked for 50% reduction in 2015 since we have doubled. And next, please. This is the paper that we just published in New England Journal. Next. Where we used a performance measure review criteria. We had 5 domains where we talked about importance of measure, appropriate layer, clinical evidence-based, measure specifications, and measure feasibility and applicability were the 5 domains, and I can talk to you about it in more detail separately. I want to get to the results section for this next. And what we found out, we used the RAND UCLA method. Not going to bore you about the methodology over here. Just wanted to put it up so you know we use the scientific methodology, which is RAND UCLA appropriateness criteria. Next. Then this is the key slide. What we found in 86 performance measures, the general internal medicine, 37% were found validated, 35% were not valid, and 28% had uncertain validity. And for only half of the measures that were endorsed by NQF and NCQA were met our endorsement criteria. Next. So where do we go from there? Click on the next slide, please. What we need to do is take a step back. We need to define terminology, as I mentioned. We need to make sure that the performance measurement is fully integrated, and we need to essentially just look at what we are doing at this point in time. Next. Next. We need to figure out what are the standards for performance measurement, because we need to identify clinical areas for performance measurement. And next, please. And we need to look at best methods to develop performance measures, because that has also been a problem, because we are all looking various methodology. I think we need to work together to figure out what are the trustworthy performance measures that should be out there. Thank you. And apologies from my end. I have no idea why my computer fell apart. I ended up taking a lot of time and saying next over here. So it probably was annoying.
Great. Well, my name is Jay Lee, and thank you for passing the baton. And I'm here to talk about what measurement means for physicians. And I'm proud to say that I'm a practicing primary care physician, and I've had the privilege of caring for people across the life spectrum, and currently practicing at CareMore Health, where I also serve as Director of Primary Care. So I have one slide, and I'll spend our time here. So basically, I think the narrative that we're sharing with you, that all of us are consistently saying, is that not all that you measure matters, but it's very important to measure what matters. And so I think that's part of the challenge, I think, that has been laid out before us. And I think a lot of the metrics that have been historically, I guess, thrust upon the clinician community has largely been disease-specific intermediary metrics. And I think the philosophy that we're starting to see emerge is much like when you're packing a bag for a long trip. You sort of lay out everything that you need, and then you try to cut that in half, and then you try to cut that in half so that you can fit it onto your carry-on bag, so that you're not burdened with having to carry a large carry-on bag that you might have to check. And so I think the overall sort of framework for that is what I would call metric synchronization and sort of parsimony around metrics. And that's certainly one of the themes that I wanted to share with you today. I think along those lines, that what's really been challenging and elusive has been the values. We talk a lot about value-based care, but what are the values that we want out of a system? And how do we ensure that the value-based system reflects the values that we really want out of our clinician community? And so before you see a photo of Barbara Starfield, and I think and for those who are maybe not as familiar with her work, I think one of the important things to pull out of this lecture or this webinar are to remember what those 4 C's are. And it does take some practice to remember them. I always remember 3 out of 4, and then I was having trouble remembering the 4th, but now I've done this repeatedly, it just kind of slips off the tongue. So number 1 it's first contact care. So the best example I can think of is when you have something going on in your life as a patient and you need to reach out to somebody, the first place that you're thinking about reaching out to is your primary care practice and the team surrounding your primary care physician. Secondly, the care needs to be continuous over time. And the way I sort of view that is your primary care physician's office should be like Cheers on television minus the beer. And that when you walk in, people know who you are. They know you by name. And that you know that when you call, you know who that voice is behind the telephone. And so building that continuity, both from a sort of a plan perspective, you know, in terms of attribution, and then also what the patient is actually experiencing is really a very, it seems straightforward, but it's actually quite hard to sort of engineer and to live out. Next C is comprehensive and concerned for the whole patient. And so when, you know, oftentimes patients will come to me and say, oh, I need a referral to a dermatologist. And I'll say, well, you know, let me take a look at what you're dealing with. And I'll take a look and I'll say, you know, that's an area that I'm happy to biopsy for you, or I can reassure them that it's something that doesn't need to be biopsied. And, you know, the patient will say, oh, well, I don't need to go to another doctor to be seen for that. That's amazing. That's great. I can kind of come here and get everything that I need. And so to the extent that we can be able to do that for patients, we should be able to. And then finally, when I do need to ask for help as a primary care physician, ensuring that that care is coordinated across the system and ensuring that the patient is getting what they need from the system, even if it is a fragmented healthcare system. So the way I like to summarize this for patients is that you would never build your house just hiring an electrician. You would never build your house just hiring a plumber. You would never just hire a set of carpenters to do the work of what a very good general contractor would do. And as was said earlier, there's a lot of online reviews now, and it's really hard to know who the good general contractors are from the bad ones. Generally, it's good to know which ones are bad, but it's really hard to know who's going to be that right fit for you. And I think that's one of the more elusive things towards, from a measurement perspective, and moving beyond what I would say, kind of just patient satisfaction on a scale of 1 to 5. How happy are you with the care that you're receiving? And it does go much deeper than that. And I was very pleased to see Rebecca and Kurt's work published, because I do think it's going to be a big paradigm shift for us in those who are being measured and also those who are doing the measuring. And then the third thing that I would say is that, so the first two things I said were metric synchronization. The second is, how do we move towards a whole person care perspective that really reflects the values? And then the third piece of this is, I think that payment and measurement often are running in parallel tracks, much like my children when they were younger in a sandbox. They would do parallel play. And what we really want to be doing in measurement is ensuring that payment reflects measurement, and that measurement reflects sort of the payment as a proxy for what we consider to be valuable in the healthcare system. And so I think there have been a lot more effort in this arena, and I think this is an advancement over, say, managed care 1.0 in the 90s. So we're certainly in a much better spot than we were, say, 20 years ago. But nonetheless, I think being very intentional about tying payment and measurement together and looking at them together so that we're looking at things from a comprehensive perspective, I think it'd really help move the needle. So from my perspective, I think those three areas are important: metric synchronization, moving towards a whole person care metric or measurement, and then being very intentional about tying payment and measurement together so that we're incenting the right behavior in the teams. And I'll conclude by saying that data is for learning and improvement, not for punishment. I often said that as a former chief medical officer with the teams that I was leading. I'm not here to use the data to punish you. I'm actually using it so that we can learn and improve. And I did want to point out the Bodenheimer framework here for building blocks for high-performing primary care. And if you could meditate on those bottom four blocks: engaged leadership, data-driven improvement, empanelment, and team-based care. And really, in this case, we're focusing on box number 2, using data to drive improvement. Then we can start to move up the blocks to get to the template of the future. I think what we're seeing a lot of in the healthcare system these days are these newfangled ways of interfacing with patients, leveraging technology and whatnot. But ultimately, I think we have to get back to the foundations of why and how we're doing the work that we're doing, and getting back to the values. As much as we are trying to measure value, I think we need to get back to the values that made primary care so critical, and truly, we're in a situation now where we don't have the primary care workforce to meet the needs of the population. So, I think it's going to be very important that we find ways to lift up that community to continue doing the hard work that they signed up to do when they wrote their personal statements. And with that, I'm happy to pass this along to actually who I would consider arguably our most important voice, and that is our patient advisor. Next slide, please.
Thank you for having me. My name is Janice Tefty, and I just wanted to thank the 3 previous presenters where we were given an example of a measurement, a comprehensive measurement, and that is being tested currently, and Amir's overall view of complicated, how complicated the system is. But what's important, I felt, is that the fact that measurement is related to incentives and money, and that's how I often explain it to other patient and public members that I know, because I don't think a lot of people realize that measurements can often be attached to funding as far as meeting, structured whatever milestones. And then thank you, Jay, for sharing the building blocks for foundation is very important. So I'm a patient advisor, and I have participated in multiple measurement tests and endorsements of, and have most recently worked to engage other public and patient and caregiver individuals to be involved with measurement, just as an individual prompting other people. So today I'd like to talk about measurements that make sense. Next slide, please.
I think you can click in there. Yeah, I think you can click in. It'll be fine.
Okay. Let me see. It's going backwards. Sorry. Thank you. So, as a few of you have mentioned before, I know the IHI has written some of this, and of course many people, but it's not about, it's what matters to the patient versus what is the matter with the patient in measuring this. And I'm at the PCORI annual meeting right now, and I was at a evidence ARC session earlier, and there was multiple presenters. But one of the studies that came out really resonated with me, and it was about measuring or capturing second blood pressure measurements. And so it's well known that people can have white coat blood pressure, and it's high when you first come in. Either they might be stressed out when they're coming in, they're worried to talk to their doctor or clinician. And if you take a secondary blood pressure reading, that it's often less. But I have found myself, and I am aware that they mentioned this in the study, that second reading doesn't often get translated into the record. So an individual may show up as having higher blood pressure that may not really reflect their blood pressure at all. And to me, that's like a measurement. I realized, wow, that is a measurement of blood pressure reading, right? So this is something to think about. So I just made up some domains. So this is really my opinions, what I'm talking about here. But the public patient inclusion and the measurement continuum helps to ensure that issues of access, reliability, affordability, and relevance are discussed. So often patient partners or public members, caregivers are able to really bring it home in some issues where the room just goes silent and realizes, wow, we hadn't thought of that. So also social influencers or social probabilities, better known as the social determinants of health. How to include, capture, and measure them. And in all honesty, I see this as probably one of the hottest areas that's currently going on. And I know recently at conferences I've gone to, the SDOH, social determinants of health tracks are full and standing room only. So it's something we really have to look at. But how can we do that? So patient-reported outcomes, patient preferences, values, and goals, And this last week was on a call on clinical decision support services, and I realized that we don't talk about limitations. Often we talk about the preferences, values, and goals, but patients' limitations that they themselves have are just as important, right? And sometimes they may not be reiterated to the clinician, or it's one of those things they might forget if it's not on the top of their priority list. Performance measures do not really capture the bigger picture of individuals or of population health. And as Amir and others have clearly stated, that there's a lot of challenges here with so many, and how do we determine which ones are best? Are they truly validated? Complex care and beneficiaries of complex needs. How is improvement measured? And is this actually reflective and realistic? I remember when I first got involved with measurement, somebody said, well, if I'm measuring vision improvement in an individual, what if they're blind, right? And so getting, were they able to acquire glasses? Is that, an option and for your health system? And if they're blind, that's really not, pertinent, but that's a very specific case. But the reality is, if you're looking at complex care and beneficiaries of complex needs, you're looking at multiple factors that are involved, and perhaps not just one. Say multiple chronic conditions. Are we measuring what matters most matched to the patient's stated health goals? So sometimes what clinicians might feel might be the best goal for the individual of shared decision-making, informed decision-making. Informed decision-making sometimes with graphics might be the best way, informatics, so the patient fully understands what their, possible treatment, medication, or even what the diagnosis is. Are you able to, follow the treatment plan or develop the treatment plan with the patient's goals in mind? And I call this the big B, but the burden of measurements today is how to, streamline, capture. I'm sorry, I can't see this whole. I'm caught up here. So how to streamline yet capture essential clinical indicators and potential preferences, values, and goals and limitations. So the burden is, I hear about it often. I work with many clinicians as well as patients. So it's also, I think sometimes patients get frustrated. Why do they do all these tests? Why do they keep measuring this when I don't have an issue here? Or why do they measure this when it doesn't change? Or this was too high and they didn't do anything. But on the other hand, on the clinician side, where it's just gotten so burdensome and such a large part of the day is according to this, documenting, as well as there could be finances attached to it. Next slide, please. So what's next? I want to make a couple comments before I go into this that I thought of today. I know personally a lot of patients really do realize what guidelines are, even though they maybe don't know where to find the best guidelines or the most validated or what's most appropriate for their care. But I was wondering, how could we bring importance to measures, the same sort of importance to measures as we do to guidelines? And I think this is something that we could really think about in the future. So public patient involvement in primary care measurement and evidence work is going to be in a very strong growing curve right now. I know personally that CMS and others have contracted with different agencies to secure patients, caregivers, and public individuals to be on measurement panels tests right now. I mean, it's going on now. I know the people that are involved. And QF is actively seeking patient partners, caregivers, public members to be on their endorsements of measures and tests in this. By the end of the year, they're hoping to have one on each group, and there maybe should be a couple more. That was what I would add to that. And we'll see more patient-reported outcomes and, patient-reported outcome measures. But as was also stated earlier, it's a harder measurement to be feasible, and it could be more burdensome, and it might be not validated. So to have some sort of standardization around that would be really nice. And always remember that the quality of life, a patient has come in to seek to feel better. I mean, this is why the patients are there. They come there for a quality of life and to feel better, and they go to their primary care doctor. And we'll see more meaningful measures in the future as a result. And I did work, this is a little story, I worked with a rural state this year with a recovery group who wanted to get involved with measurements, and they came to me because they had reached out to their state group that was, department in the state that was working on meaningful measures had found it themselves, and they wanted me to work with them on getting involved on board because they hadn't heard back. So I did this. It was very hard, I'll be honest. It's not easy work, and I just trained them. I had a basic webinar with them. They had a lot of questions. One of the individuals that was sort of leading the group felt that it was too high level, and I tried to share this is where this is at. What really caught home with them was the fact that often there's incentives behind measures, and there may be money behind, is the incentive behind measures. So that is really what kept them interested, and they did work with the state and with other stakeholders who are some of the normal players in measurement. But it was hard, and I can't emphasize that enough. So we don't really have standardized training to have patient involvement in measurement, but I feel it's important to go forward. So last but not least, a doctor who I know in Minnesota who's the evidence guru mentioned William Osler to us at a meeting I was at, and I was so intrigued. I read up on him, and he said everybody that's in evidence-based medicine or anybody that's in medicine should really know him. So I took a quote of Osler and took the privilege of changing it a little bit to: the young physician starts life with 20 measures for one disease, and the old physician ends life with one measure for 20 diseases. And a couple other quotes. I honestly recommend to put these in your clinics. If I have clinicians on the line, I have never seen any of these quotes in any clinic I've ever been in, but I really feel it would help to put the patient at ease. Listen to your patient. He's telling you the diagnosis. It is much more important to know what sort of patient has a disease and what sort of disease a patient has. So there's many more of his quotes, and I really think that patients will just it brings home that we're all this whole, person-centered care, whole-centered care, and that it just might not make the clinical environment it just might be more welcoming. Is a better way to put it. So thank you for your dedication and time, and I'm willing to answer any questions afterwards, and I wish you all the best in your measurement endeavors going forward.
Well, thank you so much. I want to thank all the panelists. I think all of us were sitting here, and it's hard not to think we were part of a conversation that's moving the dialogue forward. We received a few questions, and we have time for just a few. Rebecca, there were some questions about how folks would be able to access your measures, and a very specific question then related to representation who works in the Indian Health Service. And as I understand the question, any measures that are used need to be OMB approved. So there's a question about whether that has taken place with your work.
Sure. So we have a website. Our website is green-center.org. I think it's on one of my slides, but it's green-center.org. And on our website, you'll see a menu that says Measures Work. The measure in all 28 translations, the paper, the published validation is all available there. The information from the Starfield conference and the crowdsourcing is all available there. And there is the ability on that website to contact us if you wanted to use that instead of my email. We don't yet have OMB approval. That is another one of the things in process. We don't usually get that question. So that's clearly somebody who knows. And in terms of representation, among the 2,200 people that we fielded the measure with, 20% of them self-identified as a minority. In the crowdsourcing that we did ahead of creating the items, 21% of those people self-identified as a minority. We have a distribution of people from income ranges of less than $10,000 a year, and we had over 10% at less than $10,000 a year. We had 50% of our sample at less than $50,000 a year. And we had 10% who earn over $250,000 a year. We had from all states. We had from urban and rural settings. We had people who spanned the spectrum in age, as well as almost even split in gender, and every state and territory that is in the U.S. I think I got all your questions.
Thank you so much. I know we're running out of time, but I think all of our presenters really surfaced to us that measures are important. No one's disagreeing with that, but let's make sure we're assuring that we're using the right measures for the right purpose and they truly matter. I'm going to be bold and ask all of our panelists today one question, and if you could give us your 30-second elevator speech answer. But if you have one takeaway from what you shared today, what would it be with those who are participating in the webinar? And we'll go in the order as people presented. So Rebecca, would you answer that question?
Sure. My one takeaway would be that we need measures to be aligned with the purpose they're trying to serve. Means we need to be clear about our language, and that the measures have to be shaped to fit. We need to know the difference between professional clinical decision-making measures and performance measures. And as a form of self-authorship, the way we define who we are and the value that we offer, we have to be assessed by things that actually match up with the reasons people seek care and the reasons that they engage in care delivery.
Thank you. Amir?
I would go to what I think Janice did a phenomenal job. I love that presentation. I think we need to listen to what our patients are saying, and perhaps it is time to take a step back. Should the measurement be used for accountability purposes or payment purposes? What is the goal for performance measurement? And I think we need to take a step back also to think about if we're going to take that. I agree. No one is saying we shouldn't be using measurement. What is the goal and how to do it right, rather than sticking to the current methodology of continuing to follow the path that we have all been working on. And one thing that is pretty striking is a lot of us are working on parallel efforts, but perhaps it's time that we start working together as best as possible.
Thank you. Jay?
Yeah, I would say the takeaway for me is really sort of the distinction between value and values, and how important it is for us to go back to values. And as we're all leading in our different organizations, that this is not being done in our individual silos, that we really need to exercise meta leadership to get to a point where things are better synchronized, so that this is helping not only our patients, but also our primary care practices on the ground.
Thank you. And Janice.
Thank you. I truly believe that it's important to have all the stakeholders, clinicians, patients, just to have less burden involved with measurements, and that they're meaningful. And I would recommend to have some sort of focus groups, or actually at the national level, where we could have different stakeholders come together and discuss really what, take a look back and make things more simple instead of more complicated, and how can we do that, and what is the most important areas to be assessing and measuring so that are valued. I agree. Thank you.
Thank you so much, Janice. So thanks to all of you today, our experts, for your insights, and thanks to everyone for joining today's webinar. There have been several questions. Yes, the recording and the slides will be available on the PCPCC website. There will also be some additional information as well, so please check that out. Remember to think about PCPCC, the annual conference coming up, and also registering for our upcoming webinars. But again, thanks to all of our experts, this critically important topic, and we thank everyone for joining our webinar today, and we will close.